Thank you so much. It's a great pleasure to be here. So we talked already in the previous session about the expected growth in TAV cases, redo TAVI, and the potential for dramatic increase in cases that will be considered at risk for coronary obstruction. And we know that we described vascular issues in the previous talk. There are adverse events and there are adverse events. Coronary obstruction is not another complication. It is a nasty, dreadful, life-threatening complication that is something that we need to identify before we do a case and to prevent as much as we can. The most common technique to prevent coronary obstruction in TAVI is stent-based technique, chimney, snorkel technique. That technique is effective. It's not physiological because we are using a stent to deflect a leaflet. And stents are designed for atherosclerosis. They are not designed to push leaflets away. And the origin of the problem is the leaflet. And therefore, maybe I'll skip some of these slides. We know that there are issues related to stent techniques. The origin of the problem is the leaflet, and we need to treat the leaflet or to modify it in a way that it will not cause the covered skirt phenomenon. So this is the introduction for the topic of leaflet modification. Leaflet modification, I believe, would be in the next couple of years one of the most important topics within interventional cardiology, because eventually, although it started with Basilica, Lampoon, with very basic techniques, eventually we will have dedicated tools that will help us in the cath lab. So we understand around a decade ago that a single split on a leaflet can prevent coronary obstruction. You just need to make a vertical tear on that leaflet, because when you push that leaflet, after that tear, the two parts of the leaflets will splay and there will be a gap. And then through that gap, the flow to the coronaries could be maintained. Here you can see on the left without doing a leaflet split, and on the right with a leaflet split and pushing the leaflets. So we are able to prevent coronary obstruction by doing that. I'll not dwell on that too much, but there is a lot of science around leaflet splitting. It's not something of cowboys. It's we need to understand where to perform that slice. Basically, the size of that splay will depend on the position of the wire traversal at the beginning or the start of the cut. The lower we go, the bigger would be the splay. On the centricity of that cut, so the more central we are, the larger would be the splay, and the oversizing that we apply to that leaflet. The more we push that leaflet, the bigger would be the splay. So obviously, we do want to push that splay away and to have bigger gap between the two leaflets. You can see like an image showing why leaflet split may prevent coronary obstruction. So the first in-human Basilica procedure, it's almost 9 years ago, and we did it in Basilica in several cases, in Seattle, several cases of Basilica. Unfortunately, not many centers worldwide, or not enough, are doing leaflet modification. Do you do?
I agree with everything you said. It's a great start. We do leaflet modification. I think it's essential. Like you said, it is key for what we do now and what we'll have to do in the future. And it is, I think we need to start doing it in order to have do not have the feeling of insecurity. If you have not done it, then it's very, very difficult to start compared to all the other things that we do in the interventional world. But if you do start and you have somebody who is guiding you, then it's such an elegant solution.
Obviously, this is something that could be taught. It's not rocket science. You need to understand the concepts and to have some experience with it. Like if I tell you that we can go through the radial artery and put a stent in the mid-LAD of a patient with in acute MI, you would say this is nuts, right? So obviously we have the ability to do very wonderful things in the cath lab. We just need to learn how to do it. So unfortunately, Basilica is complex technically. It's something that could be taught, and it's not shy of adverse events, different adverse events that can happen. And eventually, when you do complex procedures and people do not have a lot of experience, then you run into trouble. This is how a double leaflet evolute or core valve procedure can look like. It's a demanding procedure. It can take many hours. So obviously, the future of that field is not just traversing leaflets, in my opinion, with wires, electrified wires, and working on them. It's using dedicated tools. Fortunately, we have a dedicated tool that was approved by the FDA already around almost 2 years ago, and it is selling as a leaflet modification device. And it's a small company, Israeli company. Unfortunately, it's not being bought by anyone yet, but it's doing a lot of cases in the United States, and it's selling very nicely as a small company. The data on the pivotal study.
Do you know how much a device like this costs today?
$60K for 4 devices.
I know about 80, but
okay.
Close enough.
Yeah, a lot.
Crazy.
But they are selling a lot. Yeah, so I'm a simple physician. There are business people that take care of these type of things. So
then the splitting costs like 2 valves.
No, not 2 valves. It's for 4 devices.
For 4 devices, so it's like
$15K for one. It's like so the data on doing these procedures was published on a registry that we did on 60 cases. Basically, these cases show the efficacy and safety of that approach, and the device got FDA approval, and it is utilized here. I'll show you one case, and then we're going to talk about futuristic things. You can see evolute at risk for coronary obstruction that potentially could be a very complex procedure. We can see like the dedicated selective injection in the left cusp and on the right cusp in case with good commissural alignment. We see that the leaflets, if they are deflected, they will go to the coronary ostia. On the right side, this is RAO, severe RAO caudal for the RCA. And positioning of it's a transcatheter knife coming from the LVOT, and puncturing the leaflet, and afterwards it's just a gentle push on the wire and pulling the device, and the leaflet is being split for the right cusp and later on for the left cusp. You just do 2 leaflets by rotating the device, and later on you do the TAV in TAV. Unfortunately, no coronary obstruction, although we know that the evolute leaflet stands between the sapien and the evolute in this frame, so there is clearly high risk. Many different TAV in TAV cases with shortcut nowadays. It's almost half, 40% of the cases performed in the United States are for TAV in TAV. Shortcut is mainly being used for TAV in TAV cases. But what do we do in cases in extreme conditions? And these cases eventually will come. Here we can see a severe commissure ostial malalignment. We see that there is a commissure of a failed evolute in front of the coronary ostium, and we have no gap at all. There are no sinuses here. The coronaries are like emerging in a very abnormal place. What should we do? And maybe in some cases we should do a low implantation of TAV in TAV, like put a sapien or MyVal very low in the failed evolute with a lot of leaflet overhang, knowing that we are not going to deflect the leaflets a lot. By the way, we come to understand that there is a new complication of low implantation of TAV in TAV, which is LV embolization. There is a cluster of cases, it's sad, and we have no good LV embolization. Imagine you have a failed evolute, you're afraid of having coronary obstruction, then you say, okay, I'll put it node 4. You implant it, 10 seconds later you find that sapien like dancing in the LV. And to be honest, we don't have good solutions for that in the cath lab. And sending patients like that to the OR means in many times death. So this is a life-threatening complication as well. So, but we need to respect the option of doing leaflet overhang, low implantation of a short TAVI device inside a long device in order to allow for some overhang. There are methods to do leaflet removal in the cath lab. They are complex when you do off-label devices, but maybe in the future, this is a Israeli guy working in the north of Israeli airfield that they are working in animals now with the device, and there are other devices. This is a device from Vancouver, and as we speak, I know of at least 15 different people, I'm sure Chaim knows, that are working on leaflet modification tools. They didn't publish anything. They don't need to publish. They are trying to bring it to human cases. Basically, when we talk about leaflet modification, we need to stratify that into leaflet splitting and leaflet excision. This is how the future will look like. And maybe in extreme conditions, leaflet splitting will not be enough. Leaflet splitting is effective. It's easy to teach and do with a dedicated device. Leaflet splitting will be even more effective, but there are safety concerns related to hemodynamic instability, to embolic risk. And what do we do when we need to do it for 2 leaflets? What will happen after you do the first and you want to go to the second? So it's complex. In the meantime, there is a new player in the field of leaflet modification, a significant one, a very successful one, that is like growing dramatically across the world as we speak, which is intra-leaflet valve deployment. When we do TAVI, we deploy the valves through the orifice. But what if we deploy these valves through a leaflet? That leaflet will not deflect. And if it doesn't deflect, it will not cause coronary obstruction. So there is a strategy of unicorn. Did you do unicorns in Greece? You're doing sometimes?
Yeah, there are
or Batman?
Basilicas, no.
No, unicorn, yeah.
It's
unicorn never, I think.
It's an interesting approach. It's easier to do than a basilica. It starts like a basilica procedure by traversing a leaflet and then escalating with balloons and eventually deploying a full valve through that hole in the leaflet. This is from the original paper, but later on I did like 6 cases already of unicorns.
Danny, because it's so interactive, what would you say in terms of doing both? Because what I have observed, there are some cases when you have a really bad VTC, you have a really short distance, and you do the perfect with echo guidance, laceration, your basal, and you have the idea everything's fine. You see the splitting, and then you do have a sort of not a total occlusion, which is a good thing, but a partial occlusion. Would you say that some cases do need a combination of chimney, although you have a good basilica constellation?
It could be that adding a stent, but not behind the cage of the frame of the failed valve, through the frame. So it's not a protective device now. You have the protection, but after you do the valve, if the patient is not crushing, you bring the guide through, let's say if it was evolute that you used to treat, you bring it through the evolute. What we say, this is a orthotopic implantation of the stent instead of heterotopic. Yes. There are some benefits to it, but there are risks also. When you start to bring catheters to that gap, you can push part of the leaflet towards the ostium of the coronary and then make the patient unstable. Or we have stent issues sometimes in these conditions, and it's difficult to come back to the coronaries afterward. But Batman or unicorn are becoming more common in the field of leaflet modification. Still, as you say, in Greece, I suspect that you didn't do, and in many other places, they don't do leaflet modification. But what if I say, when we talked about it in the bicuspid discussion just before, if we start to do leaflet modification, not to prevent coronary obstruction, which is still a rare phenomenon, to optimize TAVI. So because that picture is not the future of TAVI. We don't want TAVI to look like that in the future when we do it to younger people. And we know that we have that raphe in bicuspid cases, calcified raphe. We want to be able to deflect these leaflets without a problem. So maybe if we cut parallel to that raphe, we will be able to do it. So I can say that we delayed that publication for a couple of years, but we put it in a JAK intervention a month ago. It's a cohort of 7 cases of aortic root tricuspidization out, of doing basilica parallel to the raphe before doing TAVR. In evolute cases, in SAPIEN cases, have a look at this case. This is, that was actually the first patient. You can see like the start of a basilica procedure. You just need to do it and not mid-leaflet. You need to do it like in a certain location. It's different than basilica in that way. And the calcification amount is obviously much different as well. And there you can see how the expansion of that valve is much better than what we would have expected for a patient with such a like crazy calcification in a bicuspid case. But maybe we should use leaflet modification, not only in bicuspids. What should we do like in a case like that? This is a patient with almost 10,000 calcium score, severe LVOT calcification. We really hesitate to use balloons in this type of case, big balloons. So only gentle balloons and put a valve, and this is not a bicuspid, it's just neglected AS patient, like sometimes we see patient with many years of aortic stenosis that was not treated. What should we do? I'm sure that balloons are old, anachronistic way of dealing with calcification. We need to do it, or maybe a combination of balloons and leaflet modification. I'm sure that the future will look like that. What about doing leaflet modification just to improve coronary access? This is the case with a patient with SOV of 24.6. Obviously, there will be a challenge to do coronary access later on. She's not at risk for coronary obstruction, but maybe if we slice the leaflets, that will be easier. I'll finish by describing a case. Extension of the field of leaflet modification to something that is a bit different. A 75-year-old lady with AR, severe symptomatic AR. That lady had dissection in the past and open heart surgery. They treated the ascending aorta. They left a huge dissection from the arch distally, and also the aortic root is a bit unusual. So now she's coming with aortic regurgitation. And this is what we see. She has that huge flap coming from the arch down, and she has that flap above the RCA. And let's say she is in Greece, and she's not good for surgery. She's not very old, but she's clearly not good for surgery. By the way, she came from Hadassah. She was, you know that story? What do we do with that lady? How do we treat? AR, it's not good for evolute because you cannot push that leaflet, that dissection flap. What do you do? So it's a SAPIEN, right? It should be a SAPIEN or MyVal. You want a short device. There is no calcification.
Put a stent on the side.
So we need to anchor. Obviously, what we would have done if she's only for TAVI, we would oversize a lot with the SAPIEN. We just put a SAPIEN, oversize it a lot, and cross our fingers. In most of these cases, it will be okay. Not all. We had a case in Rambam, by the way, a couple of weeks ago. A case like that, the SAPIEN, boom, went down to the LV, open heart surgery, mortality, case done. It's like it's a risky situation. Yeah. TAVI is for AS, and we are trying to use it off-label. So I'm describing a new technique based on leaflet modification for AR cases for us that do not have ability to do Jena or J valve. Jena, by the way, could not be used for large anatomy. So there are still many patients that could not be treated with dedicated devices. the procedure, and it is performed already in several cases in our facility, and also after it was published, I hear from one case here, one case there. We call it Atlas. It means starting like a unicorn. You cross the non-cusp with a wire, but you escalate into a stent, a peripheral stent. That stent is being deployed
through the leaflet.
Through the leaflet.
Yes.
The valve is through the orifice and the stent is through the leaflet. You deploy the stent not nominally. It's not. It's still. It has a waist in the leaflet. It's stuck on the leaflet. So there is leaflet stent interaction. They are together, and now you have a valve that can anchor on something. And by the way, you can do it with several stents.
That would be my question. Would you consider doing like contralateral, a second, or both B-leaflet stenting, let's say, or would you say one would be enough?
Why?
In order to have a better anchoring?
More symmetric?
Maybe because I would have the feeling that it would be more safe, or what do you think?
No, because I'm worried that I leave there something that has volume.
That is what?
Certain volume. And this volume might create in this place a PVL. So I don't see any advantage of doing this symmetrical, but
it may add to the complexity of the procedure.
Maybe, Danny, you have also a crash stent, so this is possibly a prothrombogenic, let's say, condition, right?
Could be.
Yeah.
So basically, that patient had, before we did some bench testing, we tried to understand what would be the best stent to use. At the beginning, we thought maybe we'll put a PVL closure, but it didn't make sense. You don't need a nitinol device. You need something not slippery. That was Elchanan Bruckheimer's suggestion, by the way, to use something that will have friction, will cause friction, as much friction as we can. So we don't have cipher stents anymore.
How big was the stent you used?
That was a 6 millimeter stent, a Palmaz blue stent, peripheral stent that we utilize, goes over 6 French system.
Stainless steel device?
Yeah.
Okay.
That will cause as much friction as we can. All the 014 stents, the coronary stents are not as good. We think that the non is the best leaflet cusp to put the stent. Definitely. Because
it moves there
is no coronary there. Behind it, you have the interatrial septum, which is maybe a little bit more safe to crush something on it. We see it like beautifully in the cath lab in areocaudal. It's a side view of the non. In iliocranial, it's the front view of the non. So you understand relationship even if you don't use TE. We use TE in all of our cases. So you can see the images from the case. Traversal on the left side of the screen, and then it's in left side, and here it's left front, and here is a balloon preparation for the stent to come. So, and here is the sequence. The stent is waiting here, the stent is deployed with a waist, and later on you bring the balloon of the stent carefully, not to bring the stent out, and the sapien or the MyVal will crush that stent. You still need the stent to be above the leaflet in order to anchor, and a bit below the sapien in order to come a bit below and like hug it from down, that it will not go down. So this is an image on the left from fluoro from the case, and on the right this is a CT image of the same patient, showing exactly what we wanted. And that we did several cases already. I'm looking for like a bigger registry on that, and this is one example of like expanding leaflet modification to unusual stories, but I'm sure that eventually we'll have many different situations related to that. So thank you very much for your attention.
That's really fantastic. I mean, this the case of the day, definitely, and I love it. I think it shows how creative you have to be in order to find solutions nowadays with all our issues. But it's great. How many cases do you have already?
We have 5.
5.
If you have a case, I'm coming.
Definitely. So we should
I'll find a way.
or maybe we should place like a reducer kind of device there. So it's performance.
No, I wonder why can't
but
you do
yes.
the same, but with something dedicated like a scotch. Why do you need a stand for that?
Think with me. I'm not sure. What would be that?
Something for friction.
What will cause most friction? We need something that will cause friction.
So innovative. So thank you, Danny. So we are very happy that we had the opportunity to hear from you today, and have a nice trip back home.